Hello guys, welcome back to my channel. It's been a hot minute. I've been very busy post-COVID. Everyone's coming back to the hospital who hadn't coming for treatment. I'll just get straight into it. So I've been having a few questions from my subscribers, and I just want to answer a few of them off the top of my head. So the main one that people have been asking me is, how does nursing in the United States differ from nursing in the UK? So I'll tell you, I adapted really well because even though our training is 3 years, we were trained better in terms of doing the skills. I find it here that the course is saturated with a lot of maths and a lot of biology, so certain medical terms, it's like medicine really, the 4-year course. But I found it no different other than terminology, what they knew from what I knew. And I answered the age-old question. In the UK, I always wondered why every American show you watch, all the nurses wear stethoscope as if they're doctors. Because in the UK, we don't do auscultations, we don't do lung sounds. Whereas in the United States, you have to do lung sound. So a typical day for me, with every nurse in the United States, you have to do your assessments. Your assessments are done 4 hourly. Unlike in the UK, we don't do such an in-depth assessment. So you do a head to toe assessment. You start by looking at the eyes and you do pearl, pupils equal reactive to light. And you say what level of consciousness. You do Glasgow Coma scale. And you work your way down. When you get to the chest, you will use your stethoscope and you will listen to your heart and you listen to your lung sound. Your S1, S2, and you put if there are murmurs, if there are skip beats, the charting takes into account and you have to fill every box. Then you listen to your lung sound. You're gonna put if it's clear, diminish, what you can hear, if you can hear crackles, if you can hear wheezing, and if you hear anything, you say something. So don't chart that you hear wheezing and crackles and you do nothing, even if the person before gives you report and tells you that there were wheeze and crackles. Once you finish listening to your lung sound, you move down and you listen to your tummy. You listen to all the quadrants and you listen for bowel sounds, and they're hyper bowel sounds, hypo bowel sounds, and there are no bowel sounds. So all this you take into account for. Once you listen to that, then you go down and you talk about the pelvis. So you speak if the person's got a catheter in. You also speak if there's been bowel movement and when was the last time and what it was, if it was liquid, type 1, type 2, type 3, type 4, if there are any bowel problems, what you've done about it, if they're constipated, if you have medicine. All that's in your nursing general assessment. Then you go down and you say if there's a catheter, if the patient's oliguric, anuric, if they're on dialysis, if they have a catheter in, and you also account for if the patient's taken Lasix, how much they've peed in the last shift, and yada, yada, yada. Then you go down and you talk about the sacrum, you speak about the anus, if it's okay. Sometimes here, especially in the ICU, my patient has got like a coreg, so it's like a tube for stool. If the stool is liquid enough and there's no contraindication, meaning no bleeding or no colonoscopy due, anything like that, then the person could have a coreg, it's called, or it's a pooping bag. So the stool just comes out in there. So you chart for that. Then you go down after you finish that, and then it speaks about your pulses. So you start here, the radial pulse, you arterial, all of them, and then you go down pedal, popliteal, All of them you listen to all the way down, and you chart if you can hear them, and there's a score that comes up on the paper, 1, 2, or 3. Then you speak about if there's edema, whether pitting edema, if when you do your peripheral refill, if it fills up in 2 to 3 seconds. That's just your general assessment. It takes forever. So you do that typically at 7 when you start. You do it again at 11, and you do it again at 3 a.m. And during COVID, they allow us to not fill in every box. You could chart by exception, and you could just write the change if nothing else has changed. But post-COVID, we've gone back to normal documentation where you're filling in all those boxes again. Before, I used to think it was a tedious affair, but you could discover things that you hadn't known before. In terms of that, it's totally different in the UK. We don't listen to lung sounds. You would call your respiratory physio. I say respiratory because here you have a respiratory therapist that does all the listening. So in the UK, the physiotherapist would be the one to do lung auscultation, but here you, the nurse, you're in charge of all of that, and it's down to you to escalate to the doctor. Before I moved here, I spoke to a colleague who had nursed here, and he said he didn't feel like he had any autonomy. On the med-surg floor, I didn't. I feel like it was more doctor-oriented, but now that I'm in the ICU, I'm the practitioner who spends most of the time by the patient bedside, and I have to escalate. So I feel now more that I'm autonomous. Yes, to a certain degree, there's stuff I can do, but I can't practice medicine. In the UK, when I used to work on my cardiac floor, I'd be able to give furosemide, Lasix, as we say here. I'd be able to catheterize, give Lasix, and then tell the doctor, and he'll come and write it on the chart. That's pre-online documentation. Here, you have to run everything by the practitioner, meaning the medical practitioner. So that's the doctor. And then the doctor will either give you a verbal order saying yes, and then you can put it in under his name, or he'll go ahead and he'll prescribe whatever you need. So based on your assessment, when you do them, you escalate accordingly. One of the typical ones that I always keep in mind that I have to do and do it on time is if the patient have a small bowel feeding tube, or they have an NG or an OG and they're connected to feed. I always listen for my swoosh. You don't typically do that in the UK. You're meant to have an x-ray to make sure it's in, but here when you come on duty, every 4 hours you listen. So you pull up some air in your syringe and you do whoosh and listen for it in the stomach, and then you pull back for residual. If your residual is more than 500, you're meant to pause the feed and you're meant to alert the doctor. If it's less than, you can put it back, but use your clinical judgment. So yes, everything that you do, we go by nursing assessment. So you assess, you plan, you implement, and when you implement, you go back and you evaluate. Your NCLEX questions will have lots of those. If you're assessing and you get to pain, when you ask the person if they're in pain, if they say yes, you're meant to go off and do something about it. Chances are something is prescribed on the PRN side, you go ahead and do that. So that's typical and general nursing. Did I acclimatize well? I did. I wasn't familiar with some words and what they call drugs, but a teacher told me once that it doesn't matter where you nurse or who you nurse, you'll always assess A, B, C, D, E. You'll do airway, breathing, circulation, environmental problems. And then you would look and see what you can do about them. You identify each thing, you escalate, you do, you reevaluate. So your nursing is the same wherever you go. In the intensive care, you may not know the name of the drugs and you may not be used to manipulating pressors up and down every 5 minutes, which I wasn't, or every 3 minutes to achieve MAPS of above 65 are to achieve ideal blood pressure for someone that's very unwell. But you learn those things, and each order is given. The doctors write a lot of orders. They're predetermined the things you can do. So when you go to work, or when I go to work, one of the first thing I do, I pull up my orders. They use quite a lot of restraint here. If the patient's in restraint, we call them soft restraint. There's an order for that. There's an order for meals. There's an order for everything. Give this, and to maintain this, shut this off if this happen. So it's written. If you need anything outside of that, then you call. You yourself can also suggest what to give. Fluids are prescribed, running continuous. You do your assessment and you think the patient's dry, the blood pressure is low. You call and you tell the doctor, hello, I've seen this, I've seen that. I don't have anything. What do you want me to do? The doctor will always be on board and prescribe something for you. When I was on med-surg, the doctors typically that's looking after the patient would be at home in bed, and there'll be a hospitalist. The hospitalist would be like the doctor who covers the whole hospital. So he doesn't really know your patient. So you call and you say what's wrong and you get it fixed. In the intensive care, the patient belongs to a specific doctor. If the patient's on another floor, let's say a renal patient, the urologist would call and check up on the patient, and I also can put a page through to him. You will know at the start of your shift which doctor covers which. Just like in the UK, it's a nightmare. It's a nightmare here. Sometimes you call the doctor and he's like, I'm not looking after this patient. So your nursing will be the same yet somewhat different. I find that I've broadened my horizon and I can use the skills that I use in the UK because our skills are more practical. We wrote less essays, believe it or not, for those people rolling their eyes thinking that, oh, they write a lot of essays in the UK. Here, they do a lot of biology, they do a lot of maths, and they do a lot of writing, critical thinking, and they use lots of terms that I'm not familiar with that I had to go and look up. Apart from that, it's the same. Their pumps, we typically use Alaris, and everything is programming. So all your medicine you pull from the Pyxis. Once you pull it from the Pyxis, you scan. Once you scan, then everything for the patient comes up. You don't have to worry much about how you're administering your medication. You scan it, you upload, you see what's due, and if the medication isn't due, then you can always put it back. So it's fairly simple, much easier than in the UK. So that is a typical night or day shift as I've had in the US, and every nurse will do this. Don't forget to like, share, and subscribe.